happy Patient Blood Management Awareness Week to everyone. And we really are very appreciative of this session with the Bloodless Medicine and Surgery Society as an affiliated organization to SABM. And of course, congratulations to Nat and to the team and to everyone who's worked so hard to make today possible, and previous meetings as well, since this is the 7th meeting. Just a couple of images from a couple of years ago when I did have the privilege of actually going in person, when we did things in person, to Nigeria for a previous meeting. And here's with some of the wonderful people involved with the BMSS there in Calabar for our meeting with Abigail. I think she's on our group here of panelists, my dear nursing friend and colleague standing next to me in that picture. And I did have such a nice chance to spend time with actually a lot of the nursing students there at the University of Calabar talking about bloodless medicine and surgery at that conference. So some nice memories. Again, looking forward to when we can all be together in person, hopefully more and soon. So a couple of the objectives for today's talk, because again, I was asked to speak specifically about the connection with quality safety, bloodless, and the efforts that we are all making. So we're going to talk a little bit about the framework of bloodless medicine and surgery, particularly as it relates to nursing quality and safety in bloodless programs. I'm going to introduce to you to the nurses in the audience. This is probably not going to be an unknown, but the QSEN framework and what that means in quality and safety in both nursing education and nursing practice, to try to sort of speak the same language that our quality and safety colleagues do when we talk about bloodless efforts and programs, and really how this fits into the current model of both nursing education and also these newer concepts of blood health and blood failure. For those of us who heard a little bit of this at SABM, I'm sorry for the repeat, but I know not everybody was at SABM. So for a little background, and at least many of you, if joining from the United States, and I think a number of countries in Europe do this same poll every year. This is the 2020 poll, which looks at the most trusted professions for honesty and ethical standards here in the United States. And year after year, nurses are actually at the top of that list. And that's not said just to show off. They go a little deeper into that, and they actually look at the honesty and ethical ratings of medical professionals, and even amongst physicians, pharmacists, and nurses. Nurses always come to the top. So again, it's not bragging rights, but what does that really mean, and what are our responsibilities as nurses, as part of a multidisciplinary team? We play a very special role in both patient blood management and in bloodless medicine and surgery programs. Again, that is a reward, but it is also a responsibility. And we'll talk a little bit about what that really means. So again, this is the SABM session. So you heard yesterday from, or the day before, I'm losing track, from Dr. Steve Frank about sort of this intersection of patient blood management and bloodless medicine and surgery, which are not in opposition to one another. And many of you on the call have been part of this sort of progression or evolution, where many programs and really this initiative in PBM started in really the bloodless world, right? With many of us here on this call. Again, I'm not the only dinosaur in the virtual room who have been involved very many years and really got the start in taking care of patients for whom blood transfusion is not an option. But this is kind of the guiding philosophy that we always used, certainly at Englewood, and mentally continue to use. That really patient blood management should be that standard of care for all patients. And we like to call it the fork in the road principle, that really up until that fork in the road, really we should be treating all patients the same way. The way we look at anemia and coagulation management and blood conservation and patient-centered decision-making, it really shouldn't matter if a blood is an option or not for patient. Then at the fork in the road, right, there may be, from a clinical perspective, an indication for transfusion for some patients if they are willing to accept it. But up till that point, there really should be no difference in care. And that's where PBM is a standard of care. We know even when we get to that fork in the road, where there may be, based on the scientific literature, a true indication for transfusion, that overuse factor of blood that is used is very, very high. We know 50% or more in red cells, maybe even 90% or more in plasma. We're not here today to talk about transfusion, but this is sort of the philosophical underpinning. And then when we get to that fork in the road, this really is about the way we communicate that information between patients and caregiving team, and even amongst ourselves as a caregiving team, and that's where nurses play a crucial role in facilitating some of those conversations. This is a bit of a review for some of you, for others perhaps not. Our new definition of patient blood management, as you know, this has been accepted for publication in Anesthesia and Analgesia for their special edition dedicated to patient blood management, which will be coming out in early 2022. It will be coming out EPUB ahead of print very shortly. It is this patient-centered, systematic, evidence-based approach to improve patient outcomes by managing and preserving a patient's own blood while promoting patient safety and empowerment. Many of you, or most of you, have seen this definition already, as well as the public version of the definition. But I will point out one thing on this special Bloodless Day that we are here together, that this last phrase about promoting patient safety and empowerment was very key for those of us who worked on this project with this global definition, because this is not just an homage, but it's really a recognition of how much of this started and continues to be an important piece of it. This recognition of patient-centered decision-making, patient rights, and the bloodless roots of much of what we do in PBM. And I hope that this definition really encapsulates what we're trying to do both in PBM and in bloodless medicine. So many of you know this already, but there have been the endorsement of many societies from around the world in this global definition, so that we are speaking with a unified language. So well, let's now get into what we're here more to talk about today, and that's specifically bloodless medicine and surgery settings, nurses' role, and quality and safety. So we'll review the definition for bloodless, really we just did for patient blood management. Obviously they're related, but again, a focus on really patient outcomes and improving those using clinical strategies and medical and surgical care, right, without the use of donor blood components. And I talked to Steve yesterday. He gave me permission. With permission, I'm using a version of his slides, Dr. Frank, that he showed a couple of days ago, and showed really these overlapping principles in patient blood management in bloodless medicine and surgery in this Venn diagram, where really most things do overlap. Now, there are some elements of both PBM and bloodless medicine surgery that sort of fall outside of that overlapping part of that Venn diagram, right? So for bloodless patients, for example, there are certain legal concerns or certain documentation things that we must take into consideration that may not exist for all other patients. On the other side of the Venn diagram, for patients for whom blood is an option, there may be a clinically indicated place for the allogeneic transfusion of cells, platelets, or plasma, right? But where do we overlap in so many of these principles? And actually, again, in my dinosaur mode, I actually, believe it or not, still pulled out some notes from the first Bloodless conference or Congress held. I'm not sure if any on this call were actually there back in 1995. And the first meeting we ever had to talk about bloodless / what we now call PBM was actually led by nursing. And we had this meeting and pulled out what we thought were the pearls from that meeting, or the general principles of bloodless care. I'm not going to read them all to you, but it's very interesting, right, in terms of planning and blood conservation and proactivity and anemia management, intervening quickly, modifying our routine practice, consulting early, transferring patients as needed, restricting phlebotomy blood draws, better managing peri-op anticoagulant drugs, working out emergencies and dealing with ethical issues, stopping bleeding, right? So these principles, we wouldn't deny any of them to this day. They're still applicable and pertinent to what we do both in PBM and bloodless. These really should apply to all patients. We realized that this, again, was sort of the birth of the concepts of patient blood management. And these all should apply to all patients. We all believe in that on this call. But getting back to nursing, what we have learned, and if you have done the examination of the literature, there's still very little in the nursing literature. So I would say, as a call to action at this moment in the middle of this talk, is I encourage my nursing friends and colleagues, wherever they are in the world, to please contribute to this academic literature around bloodless medicine and surgery and patient blood management, because there really is a dearth of literature in our field as nurses. So what we did to contribute a little bit to that literature in a small way is we thought, well, what are nurses really learning about the principles of patient blood management? And again, in turn, bloodless, because of this large overlap of the clinical principles. So this is something that we presented as an abstract at SABM just a few weeks ago. But we actually did a project where we surveyed U.S. nursing schools, CCNE and ACN accredited U.S. nursing schools across the country, 104, and we actually had a 22% response rate, which, as you know, for survey projects is actually not too bad. And we just asked at a very high level. Again, when you ask too many questions on a survey, people don't answer it. But we asked at a high level, how much are you including these concepts in your nursing school curriculum? Do you even know what we're talking about when we talk about patient blood management? So we looked at our 4 quadrants, as you all well know, in patient blood management: anemia management, coagulation management, blood conservation, and patient-centered decision-making. I'll show you those results here on your screen in a moment. So we found out that the term patient blood management was not known by most of the respondents. 74% had never heard of the term. And then we asked them, what did you think we were really talking about when we asked you about the term patient blood management? And it seems like nobody really knew. It was sort of a scattered set of answers. Was it transfusion medicine or anemia and bleeding or blood conservation? People really were not familiar with that term. So we got a little deeper, asked again specifically about some of these concepts that make up both the fundamental aspects of clinical care in bloodless and PBM. How about anemia prevalence and management? Most programs said that they did cover it. Most covered it in, you can see on the right side of your screen, in a medical surgical nursing area, but did cover it through a lot of other clinical areas. Bleeding and coagulation, the majority answered, 95+% answered that they did cover this, as you would expect. In nursing school curricula, again, mostly in medical surgical nursing and critical care, but again, scattered across the different subject matters. We asked about patient-centered decision-making, as we would hope is the case. This was covered and really in an ethics patient education section within their discipline. So some of this was good news, right, in terms of a high-level concepts around PBM. And this really was our final question: is how much do you want to know? If you didn't know what PBM was, which most of you did not, and again, we sent this to faculty and to deans of these schools. I should have started with saying that. How interested are you including patient blood management in these topics, or expanding them more, incorporating more of them in your curricula? And we had a good response, from at least 3, 4, and 5s, that a good number, certainly more than half or the majority, were interested in including more content. So again, a call to action for our nursing colleagues on this call and others. Inclusion of more content for nursing school curricula, at least in the United States, is more desired and absolutely necessary, along with contributions to the literature. This was an interesting article I found. When you do a literature search specifically to bloodless and nursing issues, there's not much, truthfully, but this was an interesting, little paper. Those of you on the call probably know this more than I, because it was actually an African paper out of Ghana, which looked at the awareness of, in this one particular teaching hospital, of bloodless medicine, and found that half the nurses were aware of bloodless medicine and strategies around it. So again, I don't know a whole lot about that hospital. The paper didn't describe it a lot, but I would propose to say it would be quite different in most US hospitals, perhaps those who have organized transfusion for your bloodless programs. There would be a greater awareness, but I would say this was atypical and complements to whoever these folks are. You probably know on the call in this institution, but we certainly, I think, worldwide could do a better job of expanding that knowledge. So let's talk for just a couple of minutes specifically, again, about nursing quality and safety and how that ties back to bloodless medicine and surgery. These are names you know, particularly in the United States or the UK. There are lots and lots of well-known quality and safety organizations, the AHRQ, PCORI, IHI, the NHS, the NPSA in the UK. But not many are directly related specifically to nursing quality. So I thought it would be interesting to look at something called the Accumen, the Quality and Safety Education for Nurses Institute. Again, many of our nurses on the call today or on the Zoom today probably know this organization. If not, I'll tell you just a little bit about it, tie it back to where bloodless fits in with these nursing quality measures. But Accumen exists, and I won't read this all to you because you can read, but really to impact future and existing nurses with the knowledge, skills, and attitudes that they need to improve both quality and safety in the healthcare systems they're in. And where did this Quality and Safety Institute initiative come from? It came as a byproduct of the Institute of Medicine report, which many of you are familiar with. In 2002, it was refreshed in 2012, but it looks at opportunities to really improve quality and safety in our healthcare systems, and what were the really areas of emphasis and the fundamental building blocks of that. It was a lot of emphasis on communication, and again, as a byproduct of this effort, this QCEN organization was formed and looked at these very specific competencies for nurses in quality and safety, both for undergraduate and for graduate nurses. And these are the updates to these. Most recently, these are the 6 competencies that this organization felt were critical for nurses to be experts in, essentially, to help contribute to quality and safety in their organization. So we don't have time to go deeply into all of these, but I thought it'd be interesting to say, where does bloodless care fit into this existing quality framework? I find that many times there's sort of a disconnect in the language we use in patient blood management and in bloodless with the language that is in common use in patient safety and quality in organizations. And it's very important for us to sort of speak the same language and look to see where these things tie together and how they fit into the framework. So I'm not going to go deeply, but just a couple of points on each of these key competencies for nurses in quality and safety and where bloodless fits. So this first one, patient-centered care, almost seems like a no-brainer, right? What is more patient-centered, perhaps, than bloodless medicine and surgery? This one highlights the importance of patients' preferences, values, and needs. And really, obviously, in the case of bloodless programs, we are recognizing patients' preference to decline, and we don't say refuse, right? Decline the use of blood components based on their religious or personal values. It really is this ultimate example of patient-centered care. The second competency is teamwork and collaboration. Again, perfect example. Bloodless has a perfect fit. Nurses really can be the central node of teamwork in bloodless care. I will say probably the majority, not all, but the majority of bloodless medicine and surgery, anemia management, and PBM programs are nurse-led. There certainly are fantastic programs around the country that are led by people who are not nurses, but many are led by nurses and really have become, in some cases, the default, at least in the case of anemia, nurses have become sort of the default anemia-ologists, is the word we like to use here in the States, where there's not as much interest in our physician partners in benign hematology. So really an important role for nursing. Nurses obviously have a strong bias for patient advocacy. They play a key role in communicating patients' wishes with physicians and other members of the healthcare team. And really, nurses, as we know on the call, are experts in multidisciplinary care, very comfortable. It's part of everyday life, working with a multidisciplinary team, again, a direct connection to bloodless. That third competency in quality and safety in nursing is quality improvement, using data to monitor outcomes. Again, we could spend for hours talking about this, which we will not, but where's the bloodless connection? We really do need to measure meaningful metrics as to the efficacy of bloodless programs. So many institutions, because of the nature of where bloodless sits and came from in the organization, are very focused on patient volumes. That is a healthcare model here in the United States where volume is very interesting, right, from a financial perspective. To hospitals, but it isn't just about patient volumes and it isn't about transfusion metrics. I did take something from our SABM quality guide where this was applied to patient blood management programs, but I really do think equally applied to bloodless medicine and surgery programs. These are just a couple of examples. There are many others you can look at on our SABM website, but looking at, for example, the percentage of non-ICU patients who have standing orders for laboratory testing, right, or percentage of patients who are undergoing elective surgery with high expected blood loss that are screened and treated for pre-op anemia. These really are clinical quality measures, very, very important to bloodless patients, right, avoiding iatrogenic blood loss that's unnecessary and screening for anemia. These are the kinds of things that we should be measuring to speak the language of our quality colleagues in our institutions in bloodless medicine and surgery programs. Evidence-based practice, again, obvious bloodless connection, thanks to the work of many people. Dr. Frank was here a couple of days ago on this meeting. I did reference his study here from Hopkins that looked at the outcomes in bloodless patients. Many of us use this constantly in our work, but really showed that there are better outcomes associated, better equivalent outcomes, right, associated with bloodless care. So while accommodating patient preferences, we are able to really improve care by using not just speculation, but really good, solid current data and evidence from the literature. Fifth competency, safety, minimizing risk of harm to patients and also risk of harm to providers. I think nurses have this unique role, right, in patient education to describe patients' wishes as relates to particular treatments. But the second point is really a key one. A violation of patient wishes is really a moral injury, right? It's also a crime, but beyond that, it is from an ethical perspective, a moral injury, certainly for the patients, but also for the providers. So nurses can play this role in safety by protecting these rights of these patients, by preventing injury both to themselves, to their colleagues, and of course to the patients. All patients, just one point, all patients need education. Bloodless medicine patients need another deeper level or higher level of education around some of these issues, right? These minor blood fractions, as we call them in the bloodless world, techniques that may use a patient's own blood, patient rights and responsibilities, and specific documentation. So nurses can play a really key role in bloodless programs in that way. Finally, the last point, informatics, using information and technology. And again, different parts of the world have different levels of technology to in their institutions, but what is the connection back to bloodless? We can use our electronic records if we have them available to us to notify other providers of patients' bloodless status across not just one admission, but across multiple interactions with the healthcare system. We're able to document their wishes in whatever format, including advanced directives, and we may have specific protocols that are applicable to bloodless care and bloodless patients. So really those 6 competencies together recognized in a nursing quality and safety framework have direct application to bloodless medicine and surgery programs. So the last couple of minutes, and again, I apologize, some of you already heard some of this at SABM, but I really think we can't underemphasize what's the shift in dialogue that needs to happen in our conversations, both around bloodless medicine and surgery and patient blood management. We have spent many, many years, decades, in fact, leading the conversation with the transfusion issue. And not to say that we shouldn't talk about it, right? A few moments ago, I talked about the overuse factor in transfusion, et cetera. It's a piece of what we do, but really, when we talk about patient blood management and bloodless, what are we talking about? Donor blood in the blood bank, what is that precious resource? We have spent years talking about the treatment. We need to spend time talking about the disease because this is a patient-centered effort, right? So what is that precious resource? It really is the blood in the patient, keeping it in the patient and keeping it healthy. And we need to start shifting our dialogue. Again, it's not a big shift in words, but it may be a big shift in philosophy from a product focus to a patient and problem focus. So again, what is the thinking behind this? What are we really treating, right, with both PBM and bloodless care? Let's think for a moment about the way other organ systems are treated. We always say that blood is our body's liquid organ. We believe that blood and its endothelium really are a liquid organ. But how do we look at other organ systems, and when they fail, how do we treat it? How do we approach it? And how does that impact our thinking around blood and bloodless medicine? So just a couple of examples, right, from other organ system failures, and this is not going to be news to anybody on the call, but when kidneys fail, right, there's structural damage and impairment and loss of function at the glomerular level. It can happen for a lot of different reasons. When patients' hearts fail, right, and we're familiar with that term too, right, heart failure, the cells change in size, there's changes to the membrane, the electrical currents and the metabolism. When the liver fails, there's apoptosis of the hepatocytes, fibrinogenesis, cirrhosis, right? We're familiar with this concept that when cells fail, tissues fail, organ systems fail. We talk about it all the time. It's a daily part of our life in hospitals. I would propose that we've spent a lot of years in bloodless and PBM talking about the treatment, transfusion, and perhaps others, but what disease are we treating? I believe what we are treating is blood failure, and that it deserves a name and should have a name. What is the organ system? Again, as I referred to a moment ago, the blood and its endothelium. There can be problems, right, from a variety of etiologies. We're not here to talk about all of those. These could be deficiencies in plasma factors, problems with white blood cell function, insufficiency of essential elements for RBCs like hemoglobin and iron. There can be derangements in the way RBCs and platelets interact with the endothelium, leading to hyperperfusion, endothelial damage. In any case, we really are talking about failure of the liquid organ that is our blood. And here's the question: do we really treat it the same way as we treat other system failures? This concept of new organs is not only talked about at SABM or here at BMSS. The interstitium, the mesentery, have been recently recognized as sort of new organs. They've been there, right? Not new to human beings, but new to our recognition, or what we call them. We know that RBCs have a bigger role than just gas transport and systemic metabolic homeostasis. What does that really mean? And there are some papers already out there that talk about really red blood cells, perhaps, as the organ, and this science called proteomics, and the supposition, perhaps, that the cells are the liquid organ, and maybe blood component specifics are and again, the patient's own blood really are the different organs that are failing. This really needs more development. A nice YouTube video from this physician explaining why the mesentery is actually a new organ. So philosophically, just to finish this up, when we think about this organ failure concept, and if we're treating blood as the body's liquid organ, what do we do when an organ fails? The heart fails, the kidneys fail, the liver fails. Well, we first figure out what's going on, right? A thorough diagnosis of the patient. And then we may say to the patient, you may have to do something different with your lifestyle, make different changes, to have a different diet. We may say that's not enough. We have to take on some pharmaceutical interventions. We may put them on drugs. We may go a step further and say that's not enough. We need to do something invasive, something surgical to try to help you. When we've expended all these efforts, we've done all these things for a patient to try to improve that organ system failure, the last thing that we do is replace the organ. Why? Because we know that solid organs are a relatively rare, they are a super precious resource. They're provided in times of crisis with ultimate altruism. And there are a plethora of considerations, right, and plans. We don't really do this in the medical world with blood. We treat it like an IV fluid or something from the pharmacy. It's ordered quickly and easily. The question, again, really is whether we're talking about PBM or bloodless and where they intersect, do we treat the hematopoietic system with the same respect that we treat every other organ system? And do we, as clinicians or our colleagues, treat donated blood the same way as donated organs? And I would suppose that in most cases we do not. Again, this is a shift of thinking from organ failure in organs we're familiar with to our body's liquid organ of blood failing. So I would really love to see the conversation move the way it has in heart failure, terms like heart health, right? This is familiar to us, at least here in the United States, and I would say many other countries around the world. This is a concept that's familiar not just to healthcare providers, but to the public as well, right? We want to keep our hearts healthy because we don't want to be in heart failure. We can't always prevent it or make it perfect, but it's very common. And I would say I would like to see us get to the point where we really are recognizing that our blood as our liquid organ can also fail. And it is our obligation as healthcare providers and as patients ourselves and for our patients to emphasize blood health, right? That is the precious resource, the blood in the patient's body, keeping it there and keeping it healthy. So again, it's a shift of focus, it's a shift of thinking, but I think a really significant one. So in conclusion, I think bloodless medicine and surgery fits very closely with existing nursing quality measures. We need to start speaking that language, that recognized quality and safety language. Bloodless care respects the moral integrity, both of patients and our caregivers, and nursing needs to be focused, again, on overall health measures, as we are with other body systems, including this newer concept of blood failure, and more importantly, blood health. So again, thank you so much for the time and the privilege of being part of this BMSS conference today and for hosting a SABM session.